in the early stage setting, which is what I covered, it's very clear that HER2 targeting makes a big difference. So the only drug that's been tested extensively, of course, in the early stage is trastuzumab, a monoclonal antibody, which not only blocks the signaling that HER2 has with cell growth, but may also recruit the immune system. So it may have a dual mode of action. And it has among the biggest impacts we have seen on breast cancer. About what we see with hormonal therapy, where the risk of recurrence is cut in half and the risk of death is cut by about a third. So we see that also with HER2 targeting therapy. And we see it at a minimal cost of toxicity. It does rarely cause cardiac toxicity, which is a lesson learned with targeted therapy. There is no such thing as a perfect magic bullet. We know that HER2 is in some ways also involved in cardiac remodeling, and so when we target it in cancer cells, we do see those side effects. Fortunately, they're rare and we can usually control them. But what we've learned over the years, though, is that really anybody with HER2 positive cancer, except maybe the very small cancers, should be treated with trastuzumab-based therapy. Cardiac monitoring is important. Patients still recur, though, and even though the recurrence rates are clearly lower with targeted therapy, there is room for improvement. We're using the neoadjuvant model to discover what drugs might partner with trastuzumab to make it more effective. The neoadjuvant model, which is preoperative therapy, gives us a window into long-term effectiveness, because those that achieve a complete pathologic response, disappearance of all invasive cancer, actually do have a much better survival.